Tēnā koutou katoa, nā mai haere mai. Welcome to, I'm actually not sure what number Telehealth Forum webinar we're up to, but this is a really exciting one, I think. It's an opportunity again to have a listen to our international colleagues, and we're joined from Australia and from Scotland, and we've heard from our Scottish colleagues before, and it's a great opportunity to hear from them again. So Margaret's Head of Technology Enabled Care and Digital Healthcare Innovation Division in the Scottish Government. And we've got Nessa, who's hiding a little bit, but will be there to answer some questions, I'm sure, if we wish, who's the Knowledge Exchange Manager in NHS National Services Scotland. We've got Morag Harty from the National Strategic Lead of Remote Health Pathways, Technology Enabled Care from the Scottish Government, Hazel Archer, who I've decided to recall the knower of all things video, but I think her actual role is Head of Programs, and she's going to have a chat to us as well. And from Australia, we've got Nicole Bate, who's the Telehealth Service Lead from Monash Health and Monash Children's Hospital. And we've got Kate Hawkins, who's the Associate Manager of Clinical Telehealth Development, Innovation and Development from Western Australia. So thank you very much all. I am going to now be quiet and hand over first to Margaret. Thank you very much.
Good evening to our Australian and New Zealand colleagues. Obviously it's morning time with us, but I'm delighted to be able to join you, and I'm looking forward to hearing about developments on your side of the world, as well as what we've been doing here. I'm just going to give a very quick overview of work and approaches in Scotland, particularly focusing on the last 12 months, but setting a little bit of context. So next slide, Nessa. So in Scotland, we published a digital health and care strategy in April 2018, very much focused on a person-centred vision, which is set out in this slide, and really looking at the opportunities and potential for digital to transform health and social care delivery. So importantly, it was around health and social care, not just health. We're in the process of refreshing that strategy, taking account of the developments and learning from COVID. Next slide. So just briefly, in Scotland, we have a population of just under 5.5 million. We spend about 15 billion pounds on health and care in Scotland, and we're organised around 14 regional boards that cover geographical parts of Scotland. But we also have, since 2016, integrated health and social care partnerships. So sitting sort of underneath the boards and the local authorities, we've got health and social care integration. And that's been a very big policy priority in Scotland in terms of trying to focus on the citizen and how we don't have silos around the way we're working. Good progress being made, but still some work to do. Next slide. So I head up the Technology Enabled Care programme in Scotland, which has been in place since 2015. And it's a cross-sector programme. So again, covering health, care, housing, really good engagement with third sector and also our independent care sector colleagues. And the focus of the programme, it's a national programme, but the focus is on supporting and empowering individuals by working with health and care services to support spread and adoption at scale of appropriate technology-enabled care, service redesign and service change. Next slide. So I'm going to just cover briefly our response to COVID. So as I said, we had a programme in existence for 5 or 6 years. We had what we thought was a reasonably ambitious programme going forward for 2021. But obviously with COVID, we required to look at how did we respond to that. So I'm going to focus on 3 areas. One is areas of work that we rapidly had to scale up, work that was already underway, but really rapid scale up. The second was where we had work underway, but we needed to refocus that work and expand existing programs. And the third is new areas of work that hitherto hadn't been part of our program. And you can see some examples there of those areas. And I'll touch very quickly on some of these just as I canter through the presentation. Next slide. Hazel's going to talk a bit more about video conferencing and our Near Me service. So people are probably familiar with that. I know it's in use in Australia and possibly New Zealand as well. So we had a major scale up of our video conferencing services from March last year. You'll see from this graph, we had sort of just about 300 consultations a week pre-COVID. So, you know, there was a couple of our area boards that were using Near Me, and we had a program underway to really support all boards to engage, but it was relatively small scale. And we're now at about 20,000 calls a week. So that's gone from 300 calls a week to 20,000 a week. You can see a couple of dips, and that's largely linked to the Christmas and New Year break, where a lot of routine clinics and appointments would be off for a couple of weeks. And similarly, we saw a little dip with Easter break, but you can see that's coming back up again. And Hazel will say a bit more about that. The second area that Morag will pick up on is this is an example of where we had to refocus our work. So we had a program focusing on remote monitoring of health conditions, and we had a scale up hypertension program, which was our big program in Scotland. But again, with COVID, we needed to look to see how can we refocus some of that work. So we rapidly procured a platform called In Healthcare to support the development of a COVID telehealth pathway. So how can we help remotely monitor patients with COVID at home and be able to intervene if their condition deteriorated, but also working on a number of priority services in terms of that sort of remobilization and recovery. So there's a range of pathways now in progress, and again a huge shift in approach from where we were pre-COVID. Next slide. This is about digital mental health services. So you can see from this graph, we did have a national program focusing on digital mental health, but again, we had a rapid scale up of that over the last year, and you know, referrals have been increasing significantly, and we now have about 1 in 4 referrals for psychological therapies are for digital services. And that's quite significant because in Scotland, we've had big waiting lists for people accessing psychological treatment. So obviously, if you can do digital access, it reduces that, you know, significantly. And we've also recognised with COVID, there's been a huge impact on mental health and well-being for our citizens. So there's a big programme of work to continue to accelerate digital mental health services. Next slide. Telecare sits more within our social care context, and we have just under 200,000 people having access to some form of telecare provision. Many of those are older people, but some younger people as well. And it's largely a reactive service, so people need to call their alarm to receive a response. But we initiated a proactive approach during COVID and are continuing to roll that out and evaluate that. So it's around using the knowledge and information we have about these vulnerable people, but being able to proactively intervene. And we also have a big program of work with our local authority colleagues looking at our digital transition from an analog system. And that's going to allow us to integrate telehealth and telecare much more around the citizen. Next slide. In relation to new areas of work, care homes in Scotland had a big impact during COVID. And I think there's a recognition that we needed to do a lot more overall around supporting our residents and our staff in care homes. So we developed very quickly, working with our stakeholders, an action plan focusing on digital approaches in care homes. And that's got 3 main areas. One is digital foundations, which is around connectivity, the right devices, and so on. One is about a range of digital services that can be used in care homes to facilitate access to services. And the third is about leadership and skills. So we have a lot of activity going on, focusing on that. Next slide. Recognizing that in relation to access to devices and support, we wanted to focus on residents in care homes. So we've had a big digital inclusion program where we've allocated devices to care homes for resident use. And we've got a big uptake, covering 91% of care home residents currently. And we can see that in some of the evaluation we've done, this is facilitating access to family and friends, but also being able to take part in activities. And as Hazel may refer to, services such as Near Me. So we're continuing to focus on that big digital inclusion program for care homes, but also a wider going forward. Next slide. So really just to conclude, there's a lot I've focused on very quickly. Going forward, we're focusing on 4 key priorities around technology-enabled care and the digital citizen, really focusing on how we can support the citizen. So the first is about addressing inequalities and promoting digital inclusion. And again, that's become much more of a key priority in the context of COVID. The second is about engaging with staff, so sort of co-designing with citizens and staff services and approaches. The third is improving citizen access and promoting well-being. So a whole range of services such as Near Me, remote health pathways, digital mental health sit there. And the fourth, we're really keen to continue that pipeline for innovation to support service transformation. Happy to share our delivery plan, which is just about finalised, which will give much more detail on what sits under those. So appreciate that was a very quick run through of our journey. Huge learning, huge developments, but we recognise we still have a lot to do. So thank you very much.
Excellent. Thank you so much for that, Margaret. And really interesting that you're also going along that digital inclusion journey now, which I'm sure many of us are looking to right now. So now, Morag, you are going to share a presentation with us now.
Is that all right? Can you see that presentation all right?
Yes, we can see it fine. Thanks, Morag.
Thank you. So, as Margaret introduced us, thank you very much. My name is Morag Harty. And thank you. Good evening to our colleagues down under and in Kiwi land. So remote health pathways, as Margaret said, this has really undergone quite a change over the last 12, 18 months, as you might imagine. Slightly different from what Hazel spoke about, because a lot of the focus went on obviously the video consultations, stopping people coming in. So our programme had, almost the reverse. We sort of had a dip at the early days of the COVID pandemic, but as soon as services started to really catch their breath and realise, okay, this is here for the long haul, or at least longer than what we expected, we need to be thinking about something else, and we saw a resurgence there. We, as Margaret said, we had an emergency procurement, but we also went out to our boards quite early on and said, okay, what's your priorities? Where can we help you with remote monitoring? We already had our Scale Up Blood Pressure programme, which was sort of halfway through its 2-year programme. We had under nutrition and IBS were small areas that have already started. But we also, with no great sort of surprise there, the COVID-19 was absolutely, and symptom monitoring was the highest priority, closely followed by our long-term conditions of heart failure, COPD, asthma, and then also the pre-assessment for surgery. Phase 2 was chronic pain and under cardiac and pulmonary, and we're now actually into the future. So we've managed to sort of address most of these things there. We had to set up a process, and although this is quite complicated, we had this new procurement, but we had to discover, define, implement, make sure clinical assessment and everything else was all there. So there was all that, all those stages with gateways, excuse me, along the process. And when that looks quite a linear process, really what we've learned, and one of the biggest lessons we've learned, is we have to do this not sequentially. We really need to sort of bring it in, lots of this at different stages, and start it earlier. So we don't wait until things are at testing stage to discover that, okay, we also need to engage with some other of our partners and so on. So really we set up clinical advisory groups to advise, and I'll say more about what the lessons were that we learned on that one. clinical advisory groups, we had our information governance and so on. So it really was lots and lots of steps in there, making sure that what we had at the end was actually fit for purpose, and what we tried to make was a minimum viable product. And not least, we worked in partnership with the supplier as well, using their expertise. So the progress and the delays, okay, progress, we had that emergency procurement, we got the clinical pathways agreed, we got the pathway for COVID, we got initial assessment test sites. That in itself was a challenge, because as you may understand, boards were under a lot of pressure in some areas, particularly where COVID had been particularly rife. So, you know, their priorities, they were trying to prioritise, and so were we. We had to go through our cyber approval and IG. We managed to do a clinical safety. There was lots of clinical steps in there to make sure that everything was absolutely as safe as we possibly could make it, and not least, obviously, our patient information. We had help from our National Education Services Scotland Design to help us with that. Where were the main delays? Well, these were the lessons we learned. You know, approval for that minimum viable product. If you collect many clinicians around a table, then sometimes it's very difficult to get a consensus there. We had really good help from our Modern Outpatients programme advisors, who really knew the people and got that sorted. Information governance certainly took a time, and we also discovered that record integration was not a once for Scotland. We knew there was lots of different aspects there. Different boards had different systems and different checks to go through. But underpinning all of this was collaboration, and I can't really emphasise enough that really we initiated, or we stepped up collaborations we had before, or liaisons we had before. That really has given us a bedrock for going forward, and it's something through the newly established programme board that we will build on, and it's giving us a bedrock to carry on. Just to sort of end on the positives, the COVID remote monitoring service, that's up and live. We've got it in approximately half of our boards, but as you might understand, some boards, they've not been as badly hit now. So that there, but it's there, ready to use, and we've got some other pathways already up and running. COPD, heart failure is soon to come on stream as well, pre-assessment, and asthma. So we've got these things all happening. It's given us a really good background and lessons for our national procurement, which is expected. This is a longer term procurement, which is expected sometime just in the early summer. This has given us the lessons we've learned in the last year, has been absolutely invaluable in telling us how do we process this, how do we manage this, what can we do better going forward to make it more streamlined, to support our boards. We've got boards from very small boards to large. They all have their own challenges to face. So how can we support them from a national perspective and really get things moving? I don't imagine we'll ever be at the numbers that Hazel will tell you about for near me. However, let's aspire to making that something that's an option for as many patients as we can. The Scale Up Blood Pressure programme that Margaret spoke about, that was our original programme that we started with, and I'm really pleased that after a sort of small sort of tailing off early last year, the pandemic, obviously priorities were not about checking somebody's blood pressure. We're really seeing a resurgence in that now, and we're actually bringing people on who had been quite reticent before, so general practice, and we're actually exceeding the targets we had set. So really pleased about that, because earlier last year we sort of thought might not be. But however, we are getting there, and we're certainly seeing that coming. And the plan will be to transition this to the new platform, which has got greater functionality, and make it more accessible for both staff and their patients and publics as we go forward in the next year. And that's where we're going to head to next, is really seeing what's coming, what else is there, and move it from just having one single solution to actually saying, how can we move to the future? What's the problem, and how can we help address that? Not, oh, here's a one size fits all. So thank you very much.
Excellent. Thanks, Maury, for that rip-roaring through that. I really like that, individualisation sort of opportunity. That's really fantastic. Hazel.
I'm kind of conscious that last time I spoke to hopefully most of you before, we had a bit of a sort of in-depth overview of what we were actually doing as part of our Near Me programme. So I'm not going to go over the same ground again, you'll be glad to hear. But today I wanted to pick up on whether we should be talking about digital by default, because that has become a bit of a question for us as our various politicians and masters talk about default services, and us as well. And when you're doing 300 consultations a week, it's quite easy to talk about digital by default because it's such a small drop in the bucket that nobody actually bothers you. But when we get to the situation we had in COVID, where every GP appointment started off with a phone consultation, and we're doing 20,000 a week video calls, it starts to become a real question that people want answers to. So I want my slide move. But just as a quick sort of recap, the things we have found throughout COVID is that certainly social distancing, keeping people out of clinics, out of hospitals, maintaining less of a footfall across lots of services has been really important for us. And one of the new things we've been doing is working with urgent care colleagues in terms of planned accident and emergency appointments over video, rather than people actually turning up when they don't need to. Another biggie that's come out is, for some folks, it's about having a face-to-face consultation, not a mass-to-mass consultation, because for a lot of people it's really difficult for them to communicate. Wearing masks, they can't lip read, they can't see people's emotions. And also, a time where people are only just starting to venture out of their houses, they don't necessarily want to get on the bus, on a train, in a taxi, and actually go to a hospital. So there has been some real benefits that have come out of, using video during COVID. But to pinch more out of face, one size doesn't necessarily fit all. So we wanted to make a real effort to find out what it was that people actually thought of the service we were doing. So we undertook a fairly sizable public engagement exercise, and this was done in the middle of the first lockdown. So it's quite difficult to do a public engagement in the middle of a lockdown. So by necessity, quite a lot of it's online, online surveys, but we contacted lots of different organisations, groups like the Deaf Association, and all these kind of advocacy groups, to try and make sure that we counteracted that digital-only piece. And we ended up with almost 5,500 responses from various things. So focus groups, written surveys, telephone surveys, interviews with appropriate people. So we did get a good mix. These results are based just on our online survey, but these are comparable with the information we got from everywhere else. So that gives us a bit of comfort in what you're saying. And we asked people, should video consulting be used for health and care appointments? And 86% of people said yes, they should. So we thought that was a good start. We broke that down by age group, because very often we get that, older people won't like this, they're not digitally equipped. And actually, we do see a bit of a drop-off by age, but we're still at about 76% of over 75 saying we should be offering video calls. So that's not saying they'll all do them, but we should be offering them. So that wasn't it just wasn't as big a drop-off as we thought it would be. We also broke it down by disability. So people in the survey were asked, do you have a disability, yes or no? And again, slightly smaller percentage of people with a disability saying we should be using video, but that's still over 80%. Sorry if this slide's a wee bit fuzzy, but we also asked folks, what would you prefer? What's acceptable to you? So during lockdown, 80% said phone consultations were fine, 84% said video consultations were fine, and a much smaller number of face-to-face. And I think the thing that surprised us here was the fact that video calling was more popular than phone consultations. That was a surprise to us because we just thought, it's so easy to pick up the phone. But that I thought was quite a striking finding, albeit not a huge difference in numbers. And then the other bit for us was looking at equality of access. So as part of that, based on the consultation and based on work with our equalities teams, we did a full-blown equality impact assessment, and you can find that on the Scottish Government website and have a read if you're particularly keen. And the things we found from that weren't always that surprising. It helped people attend appointments in a safer manner. It improved access to healthcare by removing travel barriers. Another one was about reduced time off work or education to attend appointments. Because we do know that most people who attend appointments have had to take either holidays or unpaid time off work to go there. And it's also easier for carers, family members and translators to be involved without actually having to turn up. So there was a good range of benefits highlighted. The barriers, some we knew, some we didn't. One of the barriers that was highlighted to us was that people make assumptions about video appointments not being appropriate. And particularly this was brought out by the deaf community, who some deaf people said, can't stand this, don't like it, you don't have captioning, you don't have this, you don't have that, this, how dare you do this? And others were saying, this is fantastic, I can see my clinician, I can lip read, they don't have a mask on, there's some text chat that really helps, my translator can be here. So that dichotomy really brought home to us the fact that we can't make these generalised assumptions about what works and what doesn't work for people. One that was a bit of a surprise for us was the lack of a safe and confidential space for video appointments was highlighted. Now, this work was done at the height of our first lockdown, where people were at home, not going anywhere, and particularly for adolescent mental health, there was a view that the family members are round about, people can overhear me in the bedroom, and that was an issue for them. Another area where that came out was victims of domestic violence not necessarily being able to get out to actually have a confidential appointment, and just general sort of overcrowding of people during lockdown. So that's something that we certainly need to take note of. Another one was lack of inclusive communication materials, and that's something we are doing something about. So easy reads, translated materials, PSL versions, all that kind of stuff. And then the other one is people who are digitally excluded. So video calling is never going to be for everybody, but we do know that about 15% of people in Scotland aren't online. And there is a programme of work underway in Scotland called Connecting Scotland, which is providing iPads and Chromebooks to people who are digitally excluded. And the area that we're working on is within the care home sector. So there's over 1,000 iPads being handed out to care homes with data allowances, so that improves connectivity within the care homes. So that allows us to do our video calling with the care homes, but it allows the residents to stream music, to stream videos, to do their online shopping. So it's not just about health and care. And really, as a sort of last slide, rather than digital by default, it's really about making it person-centred. So offering video consulting where it's appropriate, considering both the clinical, the service and the social factors. So, does it work for this clinical specialty or service? And does the person want to use it? Are they digitally able? Do they have a device? But don't make generalised assumptions about who can or can't use a video call. And really, we're trying to encourage people to enable individuals to make their own choice wherever possible. And that means offering them the choice. So you can't give somebody a choice if you don't actually offer it to them. So that's our sort of motto, digital by choice. So thank you.
And I love that digital by choice. Thank you so much, Hazel. That's really great. And that's such a great romp, isn't it, through some fantastic services on offer. And that leads us really nicely to some questions that we had for our Australian colleagues to consider. And what I'll do first is I'll just ask Nicole to tell us a little bit about what they're doing and address a couple of questions for us on the way. Nicole.
Hi everyone. I work at Monash Children's Hospital and Monash Health. Well, I should clarify that. Before COVID hit, I was the Monash Children's Hospital telehealth person. And that soon changed. So we went from, I'm just looking at my stats, we went from 154 consults in February to 2,900 in March, and we topped out during our peak of lockdown at 16,000, like per month, and we were just chugging along at 16,000 consults per month. I work predominantly with video calls, so I just know that our numbers are 18% telehealth and 25% telephone. So I'm hoping to close that gap, if not flip it. That's my task for this year. And yeah, it's been a wild ride for all of us, I think. Going from nobody knowing what you did for a job to suddenly all the phones in your office ringing.
Isn't it nice to be well loved? I hope you've slept in that time, Nicole.
Oh yeah, well, as I said, I think we're all just chugging along, right?
Yeah, absolutely. So tell us a little bit about some of the biggest issues that you had in growing the service and its numbers.
Yeah, so some of the biggest issues I think would be the same for all of us. Funding models. So before COVID, it was all our regional and rural patients that qualified for being able to be billed for telehealth. So that really reduced our scope. Once COVID hit, that's all changed. So I think funding models are important. I think the technology and the clinical service needs need to be well matched for you to embark on this, because everyone has to have confidence in the technology. You also have to have a skills uplift and credentialing, if you can, of your clinicians and your users and even your patients. It'd be good if everyone was on the same page. And top-down leadership, we all know about that. Yeah.
What are the roles for clinicians and clinician engagement?
Yeah.
What do you think would be the bonus points there to get people involved?
Yeah, well, we just did some consumer work with our consumer advisory committee, and that was one of our pressure points. The consumers said to us, if you tell us why you're selecting telehealth, if you explain that to us, we're going to be more likely to do it. Tell us why it's that appointment. Or if we're having a face-to-face appointment and you'd like to do the follow-up review via video or telephone, just let us know. It's about communication and kind of what Hazel was talking about, choice. You've got to know all the choices to, know what's possible.
Mm. And have you got a program to address the digital and exclusion aspects and the inequities? Because we know there are big inequities in the health delivery for your Indigenous population.
Those vulnerable groups. That again was one of our topics that we wanted to hone in with the vulnerable groups. So our access for our Aboriginal and Torres Strait Islander population, how do we keep them on country and still build a relationship and make sure they're not having to travel with us all the time. that's still a work in progress though. We're still working through all of that, but little things like access for disability. So if somebody's trying to use a mobile device and the font is very small, or they've got a tremor and they have to enter their details all the time, how do we make that easy for them? And then just how do we have as many language, as many of our work instructions or help things just translated, so that, you know, how do we make it easy for our culturally and linguistically diverse population? And we've gotten our interpreters involved in that, so we get them to call on the phone 1 week beforehand and do a test call, which is nice.
And so the technology platform that you're using underneath the systems that you're running, Nicole?
Yeah, so I have previous experience with the platform that Hazel was talking about, which has Attend Anywhere underneath, but we use Health Direct, which has CoView underneath as well. So it's a virtual waiting area. The clinicians are logged in as team members and they just see the patients pop up in their virtual waiting area. Yeah.
And what about your booking systems? How do you go about booking patients in?
It's the same booking system as you would for a face-to-face. So it's a clinical workflow. The only change for a video call or a telehealth would be how it's flagged in the system.
That's integrated in. Yeah, no, that's really interesting.
Yeah.
And one of the, it's quite interesting to hear you use the phrase face-to-face as well, because, you know, we had the Scottish, you know, face-to-face rather than mask-to-mask. And I guess more and more we're having these conversations by video, which we consider face-to-face. So in New Zealand, we've actually moved mostly with some encouragement to using that term in person.
Yeah.
So I'm interested to know whether you guys are still sort of using that face-to-face to mean in person. Is that...
Yeah, that's very interesting. I might have to see if we can start doing that. That makes total sense. Yeah.
You have to talk to Andrew Pankhurst, who's on the line here. He's probably busy typing away in the chat. Has got some great material on why we should be using in person.
Yeah, definitely.
Hey, that's a really great conversation. Thank you so much for that, Nicole. What we might do now is just move to Kate, and we've got a few questions. David's been busy and Jenny been busy throwing some questions in there, so you might want to answer some of those as you go along. Also, Nicole. So, Kate, where are you? You must be in there somewhere.
I'm here. Can you see me now, Ruth?
Are.
Just needed the voice activation, I think.
So, tell us a little bit about what you're doing, and give us your reflections.
Well, thanks, Ruth, and firstly, thanks so much for the opportunity. It's a real honour to be on the panel today, and as is often the case with these types of things, the panellists learn as much as the audience, I guess, and I've made some notes for myself to check in with our Scottish colleagues around digital inclusion in aged care and remote patient monitoring, and also some questions for Nicole offline as well. So that's really fantastic. So as you mentioned, I'm the acting manager for the Clinical Telehealth Development Program in the WA Country Health Service, also known as WACS. And for those that aren't familiar, WACS covers Country WA. So we're a public health service provider with a really big geographical remit. So we cover about 2.5 million square kilometres from Columbaroo in our Kimberley far north to Albany in the Great Southern. And as you can imagine, with that large distances, access to specialist services is a challenge for us. And so, you know, telehealth has been a focus for WACS for many years. And like most of the panelists today, we had fast tracking of a number of, you know, specialties during COVID, and a lot of the work that we had been trying really hard to progress over many years was really fast tracked. So that was fantastic. And I guess for me too, being asked to be on the panel today, I was feeling a little bit reluctant, knowing the calibre of the colleagues within WACS who are doing some really amazing work within the telehealth and virtual care space. So we have some quite significant established services through provisioning through emergency telehealth services, inpatient telehealth monitoring to outpatient services. So we have quite a big range of provisioning. I guess for us, like Nicole, some of the issues that we faced during COVID, but also ongoing, is around funding models. So within Australia, during COVID, we had some temporary Medicare benefit scheme funding arrangements, which really helped clinicians, so GPs, allied health, to just get on and do it and provide virtual care. And now, obviously, there's some discussions around how long those items will be continued for. So I guess, funding models are continually an issue for us, but also for health service providers, just in terms of some of the costs around providing telehealth. So, infrastructure costs, resourcing for scheduling, for help desk, for meet and greet. So there's some of the things that we struggle with. And one of the big things for us in Western Australia is, I guess, a lack of interoperability and integrated systems. So, not having a really comprehensive integrated electronic medical record makes it really difficult for us to share information between clinicians and with consumers. So that's in the pipeline for us. But also, I guess, we also within country WA have a lot of issues with connectivity. So not just for our remote communities, but also for some of our regional centres where we continue to have black spots. So, there's some of the things that we need to be mindful of. And I guess, like our Scotland colleagues, we identify with some of the other priorities around digital inequities, and also focusing on how we have co-design with our communities, particularly our Aboriginal communities, and also looking at how we continue to improve access. So there's some of the key things for us, I guess, at the moment. But also what we're really trying to do is to push the boundaries. So push the boundaries while we continue to, evaluate our services, to look at what are the health outcomes, what's the patient experience, what are the system efficiencies, and also what's the provider satisfaction. And I think they're the things that we really need to be clear about, so that we can, I guess, have a good case to enable sustainable funding models.
And that's interesting that you talk about provider satisfaction as well. And I've noticed a question, I think it's come from David, just about Zoom fatigue. We've heard quite a bit about video fatigue in meetings that we're having, and how to ameliorate that. Have you had any particular feedback in that regard?
Yeah, I think like a lot of the other jurisdictions, people kind of, and for us, we have been very fortunate in that we haven't had the same level of community transmission. So for us, we have, been able to, we've done a lot of preparation for community transmission. But of course, during our peak COVID period, like everyone else, we saw a significant increase in uptake. We've also seen a bit of fragmentation of some of our platforms, and I think that has probably had an impact on clinicians and their confidence. So we've got a bit of work to do, I think, in terms of, and other panelists have mentioned that too, a critical factor is supporting clinicians. So I think that's, really important that we keep that in mind. And I think also, one of the things we talk about with clinicians is thinking about, what do you need to do differently for that virtual consultation to ensure the clinical governance and safety is the same as a in-person consultation. So I think when we consider those things, that helps clinicians, I think, get some perspective. But yes, I think there has been some fatigue. During COVID, we implemented some new platforms. So the video call, the Health Direct platform that Nicole was talking about. So I think, I can see a move to those software-based applications, which are a bit more intuitive and easier for clinicians to use. So I think that will really help.
And just in terms of that question that we asked Nicole as well, in terms of clinicians and engagement, are there any particular things that you think looking back may have made a difference, or did we just need COVID?
Oh, sorry, was that for Nicole or for me?
That was for you, Kate.
Oh, sorry. Well, I think one of the things that we learned is that, when the risk of doing nothing outweighs the risk or the benefit of doing something, people will get on and do it. And certainly we saw that with COVID. I think now we have a much bigger mandate to engage with clinicians because, COVID's done a lot of that heavy lifting for us in terms of just changing the way that people see healthcare, for them and different ways of providing care. They've seen that they can do that. But I think one of the things that we have reflected on since COVID is that, we can't stop now. Whilst we saw some significant change, we've still got a lot of work to do. And one of those things is around clinician engagement. We're actually just starting a digital health CRC project, which is actually looking at moving beyond telehealth. And one of the key things that we'll be looking at within that research project is, what was people's experience of telehealth? What are some of the models that work? How do we ensure that we can adapt those to ensure it enhances the clinician and the consumer experience? So we've done a bit of that work to hopefully engage our WACS clinicians.
Awesome. Thank you so much for that. That's really interesting. And I think we had this really great sort of fly around now of all these different pieces of work going on. It's really exciting. I think in our last, we've got 10 minutes to go, and a lot of our questions have been answered within the chat box. So people can go back and have a look at those questions and answers. And also remembering that this webinar is recorded, so you can go back and share it with your colleagues as well. In the final 10 minutes, I'm just going to do a round around all of you. And I'm just going to ask you, if you could wave a magic wand, what would be the one barrier that you would remove at this one time? And or a prediction for the future, whether that's in volumes or whether that's in, I've really got my eye on this piece and I think this is going to happen. Be really interested in your thoughts on that. And, in good, and I know that I've totally sprung this one on you, so we'll just spring it first on Margaret. We'll work through an order. What do you reckon, Margaret? A magic wand that could remove a barrier, and a plus or minus a prediction or a desire for the future.
Well, I suppose one of the things I think that I would see is critical is the focus on digital inclusion, and I think that's broader than just the hardware about having a device or having the right connectivity. It's about the skills, it's about the support. The ability to look at how people can engage with digital. And I think if we're leaving a chunk of our population behind as we, excite ourselves with what we can do digitally, then I think we're not doing what we need to do. And what was the second part? Just a prediction for the future, is it?
Yeah.
Ooh, that's a tricky one. Well, I guess given what we managed to do during COVID, 12 months ago, there is absolutely no way we would have thought we could have done what we did. So I guess it's about, my prediction is I suppose moving into, I think what Hazel was talking about, that sort of default approach that we don't see digital as being an optionality. We see it as being integrated into the way we work as we're doing now, and the way we plan and design and deliver services. So it's not a bolt-on to, a non-digital pathway. It's actually, we don't even think about it. In a few years' time, my prediction is we're not even talking about digital because it's just what we do.
Yeah, that's neat. So absolutely. Hazel?
I was going to say it's a tricky question. If I could wave my magic wand, there's no doubt we still have that cohort of people who have the view that, couldn't possibly do a video call, a digital consultation, because, in-person, face-to-face is the gold standard. And if I could wave my magic wand, it would be for some of these folks to actually think about the opposite of how hard it was for that person to actually travel 150 miles on the patient transport to see them for 10 minutes, and whether that was of value to the patient. So I think we can start to flip things around and look at how digital makes it inclusive for people rather than exclusive.
Nice, thank you for that. And any particular sort of predictions or desires for the future? I guess we've talked about one there, but
I suppose in terms of desire, I'm hoping that video consulting isn't just for COVID. We don't have evidence to say otherwise. Our call volumes have dropped off slightly, but they're still really high. So I'm hoping, my hope is that this is here to stay, and that we are seeing a real culture shift in how we deliver services to people.
Yeah, that culture shift is really important, and I guess hanging on to that is going to be the next challenge for you folk. Yeah, thanks so much, Hazel. Morag?
I would absolutely echo everything that Margaret and Hazel has said there. I think I've seen people nodding, because I think we all recognise that. I think from remote health pathway, I'd like to see that also becoming the default, because I think we can look at citizen power, and as people get reassured that this is not a second-rate service, I think that goes for video calls and for remote monitoring, that this is not a second-rate service. This is actually to their benefit, and change that culture, as Hazel said. If I had a magic wand, I definitely would want to see remote monitoring becoming the default as a precursor to calls or appointments. There's absolutely no reason why people are not enabled. But I would echo Margaret's comments about inclusion. I think there's health literacy that has to be brought into this. So it's not just about digital, it's about that whole part there. So that would be my magic wand and hope for the future. Thank you.
Excellent, thanks, Maureen. Nessa, now you've been sitting quietly in the background. I'm going to ask you as well. I'm sure you'll have an opinion on this one. I'll throw her in front of the camera, even though she wasn't expecting it.
Hang on, sorry folks, I had my camera off. I guess I'd be a little bit more, I don't know if it's more ambitious. I'd like to see eventually where telehealth, as we're describing it here today, is actually integrated more seamlessly. It's not really integrated seamlessly at all with electronic patient records, with an accessible system, whether it's health and social care, that people can connect from wherever they are, wherever they need to be, and that the staff obviously have access to the information that they require. And so video and remote health pathways are just part and parcel, as Morag said, of the normal care delivery. That's what I'd like to see.
I love the way you dream big, Nessa. I just so love that. It's just an awesome model. I can see all these noddings going, woo!
Other countries could do it. I'm sure we could do it if we just put our mind to it. So.
Yeah, no, that's great. Thank you so much, Nessa. And Nicole.
It's getting like narrower and narrower as we go along. So I think it'd be hard to wave a magic wand for one thing, because it's not, as Hazel said, with a beautiful slide that I can still see in my mind's eye, it's not one size fits all. So I think that would be hard. But at the moment, because it's in the front of my mind, I'd like to do away with the telephone is quicker conversation. That telephone is quicker than video, because I don't like that. And my data suggests it isn't quicker. So yeah, and I would like to I'm also aligning myself a little bit with Nessa here. I want it to be a time where we potentially don't exist, and that all of this that we're doing is just patient care. It's not a special name. It's not called digital health. It's just called patient care. That would be my dream.
Nice. I like that. Kate.
Thanks, Ruth. Well, I think everyone has, taken my top three. So I guess the bit that's left for me is one of the key drivers, and that's, sustainable funding models, because we obviously need those to make it happen. I guess if I am looking into the future, I anticipate we'll probably have a more integrated system across, all of governments, and not just within healthcare, but within other government agencies and also sectors. We're starting to see some, digital blueprints pop up around the place, which is really looking at not just healthcare, but those other sectors, and looking at how we can more creatively, I guess, repurpose some of our municipally provided facilities like libraries to enable people to better access care. So I guess they're the key things for me. Thanks.
That's excellent. So thank you so much, everyone. This has been a really, really, albeit very quick run through, but I think it's given us a huge amount of food for thought. And I think the discussions around inclusion and integration are obviously going to be ongoing, and about access. And one of those things that I particularly like was that discussion about not making assumptions, not making assumptions that the telephone is faster, not making assumptions that a patient would necessarily prefer to see you in person, not making the assumption that because you're deaf that you won't be able to have a video consultation, and also not making the assumption, I guess, that everybody's going to choose a particular way of receiving care. So, that discussion that we've had about providing options and opportunities, I think, is really important. I think there's lots of really great stuff that's gone on in the chat, and thank you so much for our panelists for answering a whole heap of those questions in the Q&A on the fly as well. And this leaves me to close on behalf of the New Zealand Telehealth Leadership Group and the New Zealand Telehealth Forum, supported by our wonderful colleagues at Mobile Health. Thank you very much, everybody, and share the love. Our next webinar is on mental health in another month's time. And to our Scottish whānau out there, our Scottish family, thank you very much. Have a great rest of your day. Thank you for joining us. And our Australian colleagues, enjoy your evening. You can go forth and go and get some dinner or something now, I'm guessing. Thank you very much, everybody. Ka kite.
Thanks, everyone.
Thank you. Cheers.